There you are. She's doing well.
TARC TARC is an organization of the major biomedical institutions in the state of Texas working collaboratively to develop treatments and hopefully someday the cure.
Texas is a huge state, and we have huge pool, a cadre of scientists. What's the strength is we have scientists that are all different. We have some that are clinical, some that are biological, some that are like me, social and behavioral. So because Texas is big, we have a big pool of scientists to draw from.
The big strength of TARC, in my opinion, is fostering a collaboration between individuals, because science these days is a team sport. The days of working alone in your lab and coming up with some big discovery aren't gone, but they're vanishingly rare.
People don't realize how social science is. It's a very interactive endeavor where we learn a lot from our colleagues.
Yeah, and I think it benefits the state of Texas in general, because you have now 10 locations of TARC campuses around the state, and we're all talking to each other, and so it's going to lift the entire knowledge base.
If we really want to make discoveries that will translate into a benefit for Texans, we need to be very inclusive, but we need to build more and more collaborations.
Yeah, so it's actually very important, the collaboration between institutions. I think in general, we want as many different perspectives and people thinking outside of the box as we can get.
And if we're really going to understand the full complexity of this disease, we really need a very strong multimodal approach with experts in all areas.
And the best part is there's people come from a diverse array of backgrounds, and then coming at it from different angles and different approaches, that when you bring that many people together from that many different approaches, it's truly beneficial.
Welcome to the 2023 TARC Scientific Symposium. Please welcome the Scientific Director of the Texas Alzheimer's Research and Care Consortium, Dr. Monroe Cullum. Dr. Cullum is a professor of psychiatry, neurology, and neurological surgery, and serves as the Vice Chair and Chief of the Division of Psychology in the Department of Psychiatry at UT Southwestern Medical Center. He holds the Pamela Blumenthal Distinguished Professorship in Clinical Psychology and is the Senior Neuropsychologist in the O'Donnell Brain Institute.
All right, that's quite an introduction. I hope I can live up to it, but welcome everybody. Just want to thank you all for being here. It's exciting to see so many faces in person once again, and I think we're in for a day of terrific presentations and updates on things. I'm really just going to take a few minutes to review a little bit about TARC and its history, if I can get this working. It's not advancing. That's not a good start, is it? Oh, okay, somebody's going to advance it for me, I guess. So just as a reminder, TARC originally began in 1999, funded by the state of Texas, to increase and enhance research and care in the area of Alzheimer's disease and related disorders across the state. Initially, TARC was a multi-site clinical cohort-based study where all the 4 initial medical schools that were part of TARC were contributing data to a database, kind of a minimum data set operation, which was very successful for many years. We collected over 3,000 subjects. Oops, now it's working. Okay. And in 2018, based on our advisement from our external advisory committee, we thank Dr. Peterson for chairing that committee, we moved to a grants-based program. We felt that the data collected in TARC was a valuable resource, and we wanted to encourage investigators across the state to make use of it. All 10 of the leading medical schools in the state are part of TARC, and each has a steering committee member. They're listed here. This is an active group. We meet regularly to make decisions about TARC and review the progress on the TARC grants as well. All of the grantees have to turn in grant progress reports that are reviewed, and funding is awarded as TARC is funded. We are delighted that all 10 medical institutions have received funding on a pretty consistent basis. We received over 200 applications for grants over the last 5 years, usually 60 to 70 per year in different categories. And as you can see, all the schools are represented. Some schools are submitting more than others. And this has totaled over $20 million in grants awarded to our state institutions for investigators at various different levels. If you want to check out to see what's been funded by TARC, it's on the TARC website. And we added postdoctoral fellowship training grants as well to help train the next generation of Alzheimer's and dementia researchers, which has been successful. There are junior investigator grants, there are more senior investigator grants, and then there are collaborative grants as well. In terms of productivity, one of the metrics that we look at is the return on investment, if you will. And of the, in the last biennium, we were funded about $8.5 million by the state, and that has been turned into over $37 million in overall funding from NIH and other external sources. In addition to that, Dr. Seshadri and the UT San Antonio and the UT RGV groups were awarded an Alzheimer's Disease Research Center in 2022. And then, of course, most recently, Dr. Sid O'Bryant, who will be talking later, received a huge grant from NIH to study elements of Alzheimer's risk in diverse populations. So if you add all these things together, we're talking about close to a five-fold return on investment for the state. So we're very, very proud of TARC's accomplishments. This is only a partial list. This is the publications we could find that were directly related to TARC. There are others, and we're trying to keep up with that. But we've approved 40 projects over the last 3 years, and these are individual requests from investigators to use TARC data. These are not just the grant recipients. So investigators across the state can request data from TARC. We have a lot of it, so please use it. Please send in requests. We've sent out over 5,000 samples. We have fluid biomarkers. We have rich clinical data, neuropsychological data, and much of it is longitudinal over time because that's the way TARC was originally organized. So please submit your requests for data and utilize it and apply for TARC grants. We feel, and this is also reflected by the EAC's reviews of our program, that TARC has been a success. It has been good for the state, and it's actually a nice reflection on the research going on in Texas. I need to quantify it, but it's just so heartening to hear how many investigators, especially junior investigators, have received a TARC award, whether it be a postdoctoral fellowship, a junior investigator award, and then gone on to receive their NIH funds as well and continue, and then they encourage their trainees to get TARC grants as well. So we feel like this is a really good fuel for Texas Alzheimer's research. I'm going to quickly go over the events of the day today. We'll be starting in with a data blitz at 9:30. That will be here in the auditorium. We are so thankful for University of Texas at Austin, Dr. Peterfar's department, allowing us to share the Oscar Fisher lecture series with the UT Austin, with St. George Hislop, who will be speaking at noon today. It's a rare treat to get to hear one of the pioneers in neurology speak to us, and we're excited and appreciate the UT Austin and the Fisher Series support for that. We do have a big poster session this afternoon at 2 o'clock. That'll be downstairs in the classrooms. There will be a caregiving project presentation this afternoon, and then we're going to wrap up with Dr. O'Brien talking about some of his data availability and some of the purposes of his big projects, because we also want to encourage people to start looking at Dr. O'Brien's data and thinking about TARC applications as well using that. But first, we have a special guest speaker. We have Dr. Ron Peterson from the Mayo Clinic, who has been the chairman of our external advisory board for a number of years now. Oh, hang on though, I'm getting a message here. Oh, so this is hot off the press. The state of Texas budget was introduced earlier this week, and it again includes funding for TARC at the same level of just under $9 million as in the previous biennium. And of course, we want to thank the University of Texas for hosting this award and their budgetary assistance with handling it. And overall, this will bring about $70 million into the aggregate of our funding since its inception. So that's a little bit of good news that just came in off the wire now. So anyway, I was back to, yes, exactly, thank you. We're excited about that. So back to Dr. Peterson. He's a world-renowned expert on Alzheimer's disease, dementia, its treatments, its diagnosis, its evaluation. He's commonly, if you just YouTube his name, you'll find all sorts of wonderful presentations he's done. He is widely published, to say the least. We were very, very fortunate that he was able to carve time out of his very busy schedule, arriving in Austin at 1 a.m. yesterday. So he's very generous with his time, and like I say, we're fortunate to have one of the truly world leaders in Alzheimer's disease and dementia research, but also in terms of the vision of where things are going. And if you ever needed to get an update about what is current, he is the man to ask. So please join me with a good Texas welcome for Dr. Ron Peterson.
Well, thanks so much, Monroe, for those kind words. And it's great to see everybody after a hiatus of a few years here. And congratulations. So, Debbie and Rita, you did your job with the state legislature. Thank you so much for that. Mark on the council. This is tremendous, the amount of funds that have have actually worked their way into the University of Texas system and generated more revenue for the state with regard to federal funding. I think the SIDS grant, the Alzheimer's Disease Research Center in South Texas, is really a compliment to all of you for the work that you've done. And I think TARC has been an important seeding mechanism for bringing that funding into Texas. So congratulations to all of you for that accomplishment. Monroe said, can you say just a couple of words about what's going on in the field? And I said, well, I don't know what's going on in the field and all that. So he said, no, just say a few words. So 80 slides later, here I am. I'm not going to do it. Don't worry, I'm not going to do 80 slides. But I thought I put up here a myopic view of what's going on in Alzheimer's disease, which means it's my narrow view of the field and what's happening. But I think it is an important time in the field for us to appreciate where we are diagnostically and where we are therapeutically, and maybe at the forefront of making some significant impact on this disease. Here are my disclosures, and left-hand side are companies that I've had some affiliation with. The right-hand side is our work with the NIH. But I just want to highlight this one grant on the right here. Usually people go by these slides kistoscopically, right? You can't read them. You don't know what's going on. I'm one of the co-PIs of a grant from NIH that's called the Alzheimer's Clinical Trials Consortium. And this consortium puts together public-private partnerships, and consequently, the private part precludes me from taking anything meaningful from the left-hand column there. Bottom line, I still drive a Yugo, if you know what that is, if you can remember what a Yugo is. So here's the brief outline of where I'd like to go today. And I'll try to be concise, but also give a feel for where we are and what's going on. So Alzheimer's disease over the years has been, at least in my training, has been a clinical pathologic entity. Clinical characterization, maybe you have some underlying biomarker information. That really persisted from 1984 for decades. In 2011 then, NIA, Alzheimer's Association, put together some expert groups who said, you know, we've learned some stuff about the underlying pathophysiology, and maybe now we can be more precise with regard to the diagnosis. So in fact, now they've incorporated the clinical picture with at least markers for amyloid and neurodegeneration. Then in 2018, they redid it and came up with a proposal that maybe we should define Alzheimer's disease biologically. If you have the presence of amyloid plaques, tau tangles in the brain, you got Alzheimer's disease, irrespective of what your clinical state is. That's a big change, okay? That's a major departure from the way Alzheimer's disease had been defined heretofore. So this is a research proposal, and I must say it's under revision again. So the same, well, not same, parts of the same committees are reconsidering this in the light of new biomarkers, plasma biomarkers, and the like. So it's still evolving, but I think we're going toward a biological definition of the disease. My good friend and colleague over the years, Cliff Jack, has generated a series of curves that hypothetically put the disease into a perspective. And he's done it in 2010, he did it in 2013. These are the 2022 curves, taking into account what's happened in the field. So the thinking is maybe one of the early features of the disease presentation is the presence of amyloid markers in the blood, followed closely by PET amyloid, then followed by p-tau fluids, then imaging, and other markers of neurodegeneration, followed ultimately by clinical characterization. And clinical characterization has some slippage there, depending on what your underlying predisposition, genetic predisposition, lifestyle, et cetera, et cetera. So these curves have really served as a backbone for what's been going on in the field for over a decade now. And while they've been manipulated right, left, up, down, they basically have held true. So when the data were populated in these curves, more or less, they've been fairly accurate. So that's the big picture. What about imaging? Let me just talk about a couple of papers. There's a recent paper that has come out from Rick Ostenkoppel and the Biofinder group, the Amsterdam group. We contributed from the Mayo Clinic Study of Aging, contributed about half of the data for this, asking the question, in the definition now of the biologic definition of Alzheimer's disease, are amyloid and tau really the key features? Because there's a group in Europe, the International Work Group, very good people, very bright people, have been working on it and say, you know, we're not going to call it Alzheimer's disease until we see a clinical picture in addition to the underlying biology. The NIA-AA picture said, no, if you've got the biologic features, you got the disease. So with those kinds of subtle differences in this, Rick and the group looked at how do we define then the disease? Can we shed some data on this where is A important, is T important, and when they appear early in the picture, what does that mean? So they looked at a group of over 1,000 individuals who are cognitively unimpaired, who had amyloid PET, tau PET, and longitudinal follow-up. And just cutting to the chase here, they really wanted to see, is it true that if you don't have clinical features, you have the disease or not? So what does that mean? Bottom line here is that when they looked at now cognitively unimpaired people progressing to mild cognitive impairment, the red line at the top there indicates individuals who are A minus, T minus. The, I guess it's bluish curve, the one second down is A plus, T minus, and the bottom two curves really now characterize people who have the presence of both amyloid and tau, cognitively unimpaired, and it's clear from these figures that they have an increased risk of progressing to clinical symptomatology, be it MCI or the next one is dementia. So they conclude from this that no, the A plus T plus characterization is in fact important and really means you probably have the disease, whether you're clinically symptomatic at that point in time. So I won't go through all these, but it was a nice demonstration, multiple groups of data that were coalesced to come up with these conclusions. And I think it's important for the field now to take a more biological approach to what is Alzheimer's disease. So the other key player in the field, and we'll hear from Sid O'Brien later this afternoon about work going on here in Texas with regard to plasma biomarkers. But plasma biomarkers are probably the biggest advance in the field in recent years. And this is a study, again, done by the BioFinder group, Oscar Hansen and his colleagues, who put head-to-head a variety of the blood biomarkers for Alzheimer's disease. And just cut to the chase here. Basically, p-tau217, phospho-tau217 wins as a predictor of who's going to be amyloid positive by amyloid PET imaging. And again, they looked at many of the blood markers that are out there. p-tau217 by mass spectrometry is probably the best measure. The immunoassays for 217, at least some of them using MSD platforms, are pretty good as well. So it looks like the role of plasma biomarkers going forward is going to be increasingly important. And I think with regard to underrepresented groups, it's even more important because we're not going to be able to get all these individuals in for a PET scan or do a lumbar puncture to define the disease biologically. So the plasma biomarkers may be particularly critical in that. The plasma biomarkers now have dribbled into clinical trials. So I know some of the Texas sites are involved in the A345 study, the AHEAD study, which is looking at people, again, who are amyloid positive, either at a low level, 20 to 40 centiloids or 40 centiloids and above, cognitively unimpaired, treating them with lecanemab to try to reduce the rate at which people progress to clinically symptomatic states. They're now using these plasma biomarkers to screen people to get into the trials, because prior to this, you literally had to screen thousands and thousands of people with PET scans to find a subset of individuals who might be appropriate for these studies. Plasma biomarkers now are reducing that to a significant extent. So Paul Azen, Risa Sperling, and the team at ACTC are leading this study, and I could just say, here's the curve showing that, again, p-tau217, this was done at C2N in St. Louis with mass spec, and in fact is very, very accurate at predicting who might be amyloid positive in the future, and consequently cutting down, increasing the efficiency of these studies. So imaging, plasma biomarkers are really central to where the field is now and where the field is going. So where are we now with regard to the therapies out there? We've heard a lot of stuff over the last couple of years with regard to, are these drugs working or not, disease-modifying therapies. So what does the treatment horizon look like as of today? Well, we've got the symptomatic drugs that have been around for decades now. We all use them. They're kind of okay, but they really don't have an impact on the underlying disease process with regard to progression. Nevertheless, we use them for our patients. But where we're really headed and where the field has made advances now are on the disease-modifying therapies. So Mark and I were talking about this last night, about where do these various molecules intervene on the putative amyloid pathway? Is it early on at the monomeric stage? Where are we at the oligomeric stage, protofibrils or plaques themselves? The recent data seem to suggest that the drugs that are effective at reducing plaque level, say by PET, are probably clinically effective. Now, where do they act in that pipeline? Is it at the plaque level? Maybe not. Maybe it's at the protofibril level. We don't know exactly. It's hard to determine that. But they seem to be effective at reducing plaques. And I've got a slide a little bit later that will hopefully demonstrate the importance of actual plaque reduction. So the target here is amyloid. This is not the end-all, be-all of the disease, but I think it's an important element. And I think that the recent data have suggested that, in fact, this is an important element. We may be able to intervene on it, and have an impact on outcome. So the monoclonal antibodies that are under investigation now are these four, and we've heard a lot about aducanumab. Donanemab will read out in the next couple of months. Lecanemab just read out, and we had some, I'll show you some data from that one. Gantenerumab also read out at its higher dose studies, Graduate 1 and Graduate 2. Not as successful as we had hoped, sort of halfway along the line. Removed some amyloid, something of a clinical response, but not enough. We all know about this. The 3 studies that were presented to the FDA, one was positive, one was negative, and one was, maybe suggestive. And so it got accelerated approval, did not get funding from CMS, so it's out there, it's available, but basically on the shelf. The price is up there. So that nevertheless opened the door at the FDA for consideration of approval of this class of drugs. But the new kid on the block, lecanemab, is the one I think that is probably most exciting right now, at least presented at the CTAD meeting in San Francisco in late November, early December, that really was a jolt, a positive shot in the arm for the field. So at the same time, the data were published as opposed to the aducanumab trial where publication was delayed by years after the data were presented to the FDA. So this is a credit to the team at Eisai for putting this together rather rapidly. They claim their drug is working at the oligomeric stage, at the protofibril stage in the amyloid cascade. Again, difficult to measure, but maybe. But it did have an effect on plaque reduction. So busy slide, don't worry about it. Basically, almost 1,800, I think 1,795 people were enrolled in the study, either at the mild cognitive impairment stage, mild dementia stage. All of them were amyloid positive, either by PET or by CSF, randomized then to either 10 milligrams per kilogram, IV every 2 weeks, which is a challenge, but nevertheless, that was the dose that was used, or placebo, and followed for 18 months. I'll get to the clinical outcome measures here. Busy slide, don't worry about this, except to say that this study had the foresight to enroll some of the underrepresented groups. So while the African American proportion is rather small, the Hispanic proportion gets up into the 20%. So they have 20 to 25% of the total trial population is from underrepresented groups, which is really important, as you know, going forward. This is a criticism of many clinical trials now, so I think that this is laudable for them. The other feature of the study is that they also included some medical comorbidities. Many of the trials have been criticized as being squeaky clean with regard to these. So here we have hypertension, hyperlipidemia, ischemic heart disease, diabetes, obesity were allowed in the trial. Also, people who are on anticoagulation were allowed. Now, it's only about 5 or 6% of the people. Nevertheless, anticoagulation, because of the ARIA concern of side effects, were allowed into the trial. So in that sense, it was reasonably robust. Primary endpoint for the study then was the change in the clinical dementia rating, the CDR sum of the boxes, and there were 4 secondary measures. And again, the study was designed reasonably well with a hierarchical statistical analysis approach, meaning that when you do your primary endpoint, if it's positive, then you can do the secondary endpoint. If it's positive, then you do the next secondary endpoint, and on down the line. So there was this alpha saving procedure that was used, but they were able to do it successfully. So all of the primary and the secondary measures were, in fact, positive in this study. So here is the CDR sum of the boxes, and again, you can see there's a nice separation in the treatment group with regard to the placebo group. So a rather 27% slowing, and we can get into a discussion, is that clinically meaningful or not? I'll say a couple words about that. But 27% slowing over the course of 18 months. Amyloid PET, primary outcome. This is a drug that is designed to remove amyloid from the brain as measured by PET scanning. And in fact, they went from a centilloid in the 70s down to a centilloid in the 20s, about a 59.1 centilloid reduction. 2/3 of the people in the study then who came in with a 77 centilloid level. Centilloids, if you're not familiar, 0 to 100. 100 is fully developed Alzheimer's disease, head full of amyloid. Usually 0 is don't have any. The cutoff for positivity, depending on the study, is in the 20, 25 centilloid range. That's positivity. So they, in fact, 2/3 of the people went from a centilloid in the 70s down to a centilloid in the 20s. So essentially reduced it down to normal. So they did what they wanted to do biologically. Other clinical measures, the ADAS-Cog14, ADCOMS, which is a combinatorial measure of clinical indices of performance, all of these, the ADCS, MCI, ADL scale, so a functional scale, all of these measures were positive in this particular trial. So bottom line is they met their primary, they met all their secondary outcomes, 27% primary, 26%, 24%, 37%, everything lined up in the right direction. Now, you can look back at the aducanumab trials and say, well, isn't that similar? Yeah, it was pretty similar to the positive aducanumab trial, the EMERGE trial. The other trial didn't fare so well, but in fact, this looked quite similar to those data. Side effects, yes, all these drugs have side effects. They had about a 12% rate of ARIA-E, so edema, and a 17% of ARIA-H. Not trivial. You have to be mindful. So when you go out and treat patients, if you do, with these drugs, you have to have that honest conversation with them that there is a significant probability of having one of these events. You can monitor with MRI. Most of the protocols that are being developed right now, and there's a paper under development, appropriate use recommendations for the use of lecanemab, that actually is going to prescribe or suggest how you should monitor people. If you use this therapy, how you monitor them for the potential development of ARIA-E or ARIA-H. So it is real. The drugs have this. The rate was considerably lower than what we saw with aducanumab. We'll see what happens with donanemab, but it is a real consideration. Interestingly, though, if you look at when the ARIA, the side effects, arose, 71% of them occurred in the first 3 months and 92% in the first 6 months. So that helps you in your prescribing and monitoring plan for these for the use of this drug as to when you really keep your eyes open and follow people with regard to potential side effects. So busy slide, bottom line here is infusion-related reactions, ARIA-E, and rare macrohemorrhages do occur with this drug and need to be considered. There have been 3 deaths in the open, none in the study that were related to the medication in the study in the 18-month. In the open-label extension, there have been 3 deaths, largely due to macrohemorrhages. One of the persons was on anticoagulation, if that was a factor. One of the other persons had a stroke and was given TPA to treat the stroke, and in fact had a massive hemorrhage after that. So they are real. They're something you need to consider and certainly discuss it with patients. Now, downstream, did the reduction of amyloid have a positive effect on biomarkers, downstream biomarkers? So they looked at CSF, they looked at plasma, and looked at imaging. And in fact, it looks like, yeah, it did what it was supposed to do. So here in the upper left corner, we see CSF now, A-beta 42 levels went back up. Remember, they go down in the disease. They went back up with treatment. CSF, A-beta 40 in the bottom left didn't do much. The top right, the 42 to 40 ratio, as you would expect, went up as well. And interesting, plasma, A-beta 42 to 40 in the right-hand, bottom right-hand corner with mass spec also reflected what was going on in the CSF, maybe reflecting what was happening with PET imaging. So it's important that these biomarkers, these downstream biomarkers, seem to be behaving in an appropriate fashion. And again, here's what the scans look like with the amyloid reduction on PET imaging. The effect on the CDR sum of the boxes, which was the primary outcome measure, you can look at, those of you who deal with the CDR know that there are 6 domains that comprise the composite score. And interestingly, all 6 domains, when you break it down to the individual domains, seem to respond to the drug. So it wasn't driven by one particular aspect of the CDR, but in fact, it worked across the board. And here's an index of worsening on CDR global scores. As you know, the CDR global is 0, 0.5, 1, 2, 3. And so they projected and modeled out now the rate at which people would go to the next level of impairment on the CDR, and again showed that the drug had a favorable impact on the worsening of the CDR. Then if you look at a slope analysis, well, again, I'm getting at the notion of clinical meaningfulness here, and they tried to look at, well, what does it mean if you have a 27% slowing? And they translated that into how many months of saving of function would you experience with this drug? And they estimated in an 18-month trial, you would save about 5.3 months of function. Gets soft, but whatever you're doing at this point in time, if you take the drug, you will be preserved at that level for, say, 4, 5, 6 months longer. Is that meaningful? Maybe, depending on what that is, and we certainly can talk about that. Then they got into what I call even softer scales, but everything seemed to coalesce again. So they're looking at the subject's impression of how he or she is doing in terms of quality of life. They looked at caregivers, family members, looking at the participant in the study. How do you think he or she is doing? And everything seemed to say, I think they're doing better. Again, it's a blinded study, so in fact, people on treatment seem to be doing better. So even when you get into the softer quality of life measures, it seemed to be impactful. So here's a summary. I think it was a well-designed study, well-executed study during a pandemic, and they still were able to come out with these positive results. So I applaud them. I think they did a nice study. The big question still lingering out there is, so what? Okay, you moved amyloid, so what? Is that really important? And I think that, this is where the myopic view comes in. I do some work with ASI, but I can't take any money from ASI because they are funding the Alzheimer's Clinical Trials Consortium. So I know the folks, but there's no financial involvement. I think the study did pretty well. So here's a picture now from Dr. Yaning Wang, who was at the FDA for 18 years. Finally, he retired, gone to a biotech and all that. He was intimately involved with the aducanumab trial. And he was adamant that, in fact, the data that were presented to the FDA on aducanumab really reinforced the accelerated approval of the drug. So I can go into the details later if you'd like, but he's put together this characterization. So this is amyloid reduction and CDR improvement. So on the y-axis here, we have the CDR going down is improvement, meaning that the treatment group is doing better than the placebo group. On the x-axis, going to the left, is we're removing amyloid from the brain. So is there a correlation between amyloid reduction and improvement on the CDR? Bottom left on this graph would say yes. So people have criticized the field by saying, what about all those amyloid studies that have been done over the decades that have failed? And here's where they appear. So here's a variety of these studies: bapineuzumab, gantenerumab, early lower dose studies, crenezumab, solanezumab, and then the BACE inhibitors. And you'll note that most of these points on the curve hover around the intersection of 0 and 0 on the y and x axis, meaning you're not removing much amyloid and you're not seeing much clinical improvement. So they're not doing very much. But now the next generation antibodies that in fact have shown amyloid reduction and a clinical response seem to populate the lower left corner. If you add in all the aducanumab studies at the different doses and all that, they kind of fill in that quadrant. You take away those studies that didn't move the amyloid marker very much, and I'll leave it to your interpretation. Is there a suggestion here that, in fact, if you remove more amyloid, you will get a clinical improvement? And here is the Clarity study. This is the lecanemab study I was just describing that kind of hangs out there in that part of the spectrum. So I think this is the gestalt that the FDA used to give accelerated approval initially to aducanumab and more recently to lecanemab, saying biologically, I think it's there, I think there's a signal, and it may be important. So, but what should we expect from these trials? We're going into one element of the disease now. We're reducing amyloid levels as measured by plaque, measured clinically. How much clinical improvement should we expect from this kind of an effort? And if you think about the temporal evolution of the pathophysiology, presumably amyloid misprocessing accumulates over years, maybe decades. In a randomized controlled trial, 18 months. So something that's been going on for 15 years now, you're reversing part of it at the plaque stage level, at the clinical level, in 18 months, okay? So what do you expect from that? Are we talking about disease modification? What scales are we using? Is the CDR really the end-all, be-all? It's a pretty crude instrument, pretty blunt. And the real issue is, okay, in 18 months you see this. What about if you go longer? Well, let's project that out. Presumably, if you're having something of an effect to have the curves diverge in 18 months, will that persist? You go out 24, 36, 48. Now, I think that's simplistic, though. I don't think that we necessarily should expect that reduction of amyloid in the disease process will continue to have a clinical benefit 24, 36, 48 months out. The amyloid component of the disease may be most malleable early in the disease. When you get out into the later stages, it may not be all that beneficial. So while this is a theoretical depiction, it may not be completely accurate. Nevertheless, if you go back to that notion of months of reduction, and here's a little bit more of a conservative depiction, looking here at, say, 18 months, if we slow progression on the CDR sum of the boxes by 0.5 at 18 months, this projection says you'll save about 4.5 months, maybe 6 months if you go out to 24. Then is that a big deal or not? Now, in California, if you're diagnosed with mild cognitive impairment, you can still drive. However, if you're diagnosed with dementia in California, the physician is obligated to report you to the Department of Motor Vehicles. So, I'm not saying that that's the distinction, but could a 0.5 change in the sum of the boxes mean, can I drive or not? Is 4.5 months, 6 months a big deal for me continuing to drive? Might be for some people. So, again, I'm oversimplifying and I'm going way beyond the data, but trying to put the preservation of function into some kind of a clinical context is where we're going. So, getting back to my notion that are we expecting too much of a single intervention? If we only manipulate amyloid, maybe if we only manipulate tau, what realistically might we expect? And a modest clinical benefit that we're seeing in these trials may be it. But it's not trivial. It's important. But this may be all we can expect. We're not going to stop the disease. We're not going to eradicate Alzheimer's disease with an amyloid drug. But I think we're treating now the amyloid component. So let me finish with a slide I've been using for 5 years or something like that, because it kind of wraps up this thinking. Here's your clinical spectrum: cognitively normal, unimpaired, mild cognitive impairment, and dementia. What impacts that? Well, We've been talking a lot this morning about A beta. Yeah, it impacts it. Certainly tau impacts it as well. Other things do too. Alpha-synuclein, Lewy bodies, TDP-43, particularly with aging, is an important component. Vascular disease plays in a very significant component, especially in aging. CSF dynamics, haven't talked about that, but this is becoming back onto the radar screen as an element affecting our cognitive function. And I'm sure there are other things that we haven't appreciated. So this is the complexity then of somebody who is in his or her 70s and 80s, has some degree of cognitive impairment. It's likely that they have a combination of these factors. What's Alzheimer's disease? Those two components could be very important and may be the most important elements in an individual. But in the next individual, it may be just a contributing factor to a broader picture. So now we're talking about intervening on one element, the top element there, A beta. How much might we expect? What's reasonable to anticipate in terms of a clinical impact? So where we are in the field, we've got these multiple and other factors. We're trying to develop biomarkers for them. We're better at some of them than others. And why are we doing that? Because ultimately we'd like to develop therapies for each one of those components. So beyond my time down the road, it may very well be that we have combination therapy for a person with cognitive impairment. So the person goes into the physician and not only gets a lipid screen, but gets a cognitive screen, blood tests that may tell you what your composition, what factors might be impacting your cognitive function at this point in time in your life. And the good news is, and here's what we can do about it. We've got some interventions that may. So the antibodies for amyloid are just very, very early on this picture, the first step, putting your foot in the door, but may be very important toward this strategy of trying to develop multifactorial treatment. So let me stop there and appreciate the opportunity to share some thoughts with you. I don't know if we have time for questions, Monroe.
We have time for a couple questions.
Thank you. Mark, we'll start with you. Okay.
First of all, that was fantastic. I wanted to get your perspectives on the timing. So these are people who are treated with mild cognitive impairment. Obviously, we'd probably like to go earlier, but how would we balance that against the potential complications and cost of the current therapy? And what are your thoughts about adding, we have made small molecule inhibitors over the years for beta secretase and gamma secretase. And what are your thoughts there about how we might be, how future trials might look, and whether or not an earlier intervention might bend the curve more than what we've seen so far?
Excellent point, and I think you're thinking in the positive direction insofar as where might these drugs like amyloid interventions be most efficacious. You would think earlier in the disease. Now, crude example, cholesterol lowering. Do you only give the cholesterol lowering drug after the person's had the heart attack, had the congestive heart failure? No, you want to treat it a priori 5-10 years prior to that. So very much so. I think the signal, the modest signal that we're seeing at the symptomatic stage of the disease is important because it tells us the drugs are doing what they're supposed to do. But you're quite right. Maybe if we go earlier, so there are trials, I mentioned briefly the AHEAD trial is a trial. A4 is another trial that's out there for individuals who are amyloid positive but asymptomatic at that point in time. That may be where you get your biggest bang for the buck. Now, the Lilly folks with donanemab have used the strategy of let's knock the amyloid levels down to normal, stop treating people, follow people, and maybe, Sid and his work will contribute to what plasma biomarkers might we follow then, and if the plasma biomarkers are appropriate and start creeping up, maybe we retreat and we knock it down again and we do that sort of maintenance therapy. theoretically, that might be an option. I think then the cost savings would be huge. You're not going to treat somebody with an intravenous antibody every 2 weeks for the next 20 years, but in fact, you do it on a basis to biologically manipulate the disease. So I don't know. Let's start. Yeah.
Hi, Louise McCulloch. I'm a vascular neurologist. And so, of course, my concern is always with the ARIA-H and people on anticoagulation for AFib. We do have some alternative treatments to anticoagulation for patients with AFib. But do you think that there'll be any kind of dosing adjustment? And again, redosing when needed, but kind of looking at the slope of the amyloid clearance, because there's some animal models that suggest that if you clear it very quickly, that can contribute to the amyloid going into the vasculature and being like a cerebral amyloid.
Right, right. I think these are important questions, and I don't think we know the answer. We were at a meeting, Sid and I were at a meeting last week where people were talking about, is it the rate of amyloid removal, or is it the absolute threshold that people get down to? And there's some thinking it may be the latter rather than the rate, although the Lilly folks have recently done a study with donanemab against aducanumab showing that donanemab, shockingly, removes the amyloid much more rapidly. So I think that and what's going on in the blood vessels, I personally am going to be quite conservative, and while we're developing our treatment protocol at Mayo for the actually instituting treatment with lecanemab, if in fact it gets full approval from the FDA and somebody's going to pay for it, we're probably not going to treat people with anticoagulation, who are on anticoagulants. I know it's common, atrial fibrillation is very common. You mentioned other device. You could do a Watchman device for some people if they want to go there, and some people may want to go there to clip the left atrial appendage and reduce the likelihood of stroke, and you don't need anticoagulation. So, but that's going to be, we're going to be very, very cautious with that. Yeah. Stroke is common, so treatment with TPA, I would not use TPA. I mean, I just one case I know, but it was, it was pretty dramatic in that individual. So.
Okay, thank you. We'll take a break. We'll be back at 9:30.
We will now take a short break and reconvene at 9:30.
Yeah, that's fine. Yes, sir. He's going to use the clicker.
He's difficult. Whoops, sorry. Did I just say that? No, I'm sorry. Somebody wrote.
Yeah, I was sitting next to her and I texted her. I was like, Facebook was not
Yeah, well, I gotta find Ron Peterson. But
Yeah, right.
But it was fine. So for data list, I did want to just have a quick wherever we go. We will set 8-minute timers for each speaker. Is he going to be?
he's sitting here, but he's kind of, he has it on his phone.
So the first year was going to be Sarah. Second, he's just going to kick them to the front. Perfect. Yeah, and then, like I said, everyone has 8 minutes. And then there was only 4 or 5 of those presentations that didn't have it just depends on, like, and that's what she was saying with guys. I was like, some of this content you have, pay attention for 2 hours, like, active listening.
For this group, they're like,
Okay, cool. I know, I just want, that's really good.
like yesterday, I just went, I don't have my switch each presentation because the first one got it also allowed me to, so they knew when I was walking out, I was let's go. I wish I was there. It's so great.
Show me how you touched you. There's a bad story. It's the only way to connect with them. It's there. Something terrible.
Is Rodrigo there? Fine. Should I send Rodrigo to you? Or just find out?
Yeah, I just wanted to, say hi and see how he is going to transition people on the stage. I'm going to be right back there as needed, and he could speak freely to it anytime. That's why I brought him. So like, yeah, there's a problem.
Do I give him one of the mics?
Well, so we need to talk about that. So he was over in March here, but if he wants to have one of the other mics, he's kind of not saying anything, we can do that for him here. Yeah, like how does he want to do that?
Okay, I'll ask. I'll go get him.
Okay.
I know, he just walked right in.
Yes, last year it was very long. We're about this, last year, it was about 6 months ago, but it's so I just wanted to talk through your part and see how you wanted to transition people on and off the stage. Once you come and make your opening remarks, and then you're going to have a seat. And then we have 18 presenters that each get 8 minutes. So we have a speaker timer set for them so they know. If you 5? Okay. No worries. We can check.
Sorry, I didn't even think about this.
Yeah, no worries. We'll change it. All good. So you'll make the initial remarks, and then when our first speaker is done, you want to have a handheld mic with you in the audience, where you can make remarks for the next gentleman that's going to you, or if you want to come back to the podium. How do you want to transition people on and off?
I would say that since we are in the scene, better that I stay in the seat and not come to the podium.
Okay,
Because it would be
Maybe you stand with the microphone and say something next speaker or whatever you want to say.
Yes.
Yes. Usually we talk about this.
Okay.
But I will not come to the podium.
No problem. Yeah, absolutely, sure. I just want whatever makes you comfortable is no problem at all. And then, so you'll be in charge of making sure that the next person goes by you to send them onto the stage.
So in your opening remarks, just say all the Daily Book speakers should be sitting in the front row. If you're sitting in the audience, you can sit in the front row. Please come down right now.
Yeah, and I will also remind them to there's some times I will wait for 4 minutes so you know that
Yes, and so this will count down, and when it gets down to the last minute
Perfect.
And so because some of the slides are not timed, we did leave a clicker up here just in case anyone has an emergency, they can.
Bhavya Shah just came up here. Maybe he just took it.
It's just here. All right, it's okay.
Ready to go. I'll find
Probably
him.
that first speaker. But they do have a clicker available. We're trying not to use that clicker, but the first speaker wants to use the clicker. He took the timing off of his presentation. We have 4 other presentations that are not timed as well.
Perfect.
They may feel more comfortable advancing their own slides, but we will start it. If there's an animation and it's calling for an auto advance, we will start it. but we'll leave the clicker here and they can pick it up and advance slides if they need to. So just in case anyone asks you any questions like, can I advance my own slides? Yes, they have the option to if they want to click faster than what the time allowed. So if they've made a 5-minute presentation but they're speaking quickly because they're excited about the content, they can click through their own slides.
I was practicing with my students and he was like that, so I will tell him.
Yeah, yes,
Okay,
sir.
perfect.
And then if you need anything, you just literally call for me, Amy, and I'll help do whatever we need. If you're like, Amy, clicker's stuck, or we need to go back a slide, or the speaker is not here, we need to go to the next one. Anything that arises, just speak freely to me, and we'll work on the back to get the next PowerPoint queued up.
Perfect.
Okay?
That sounds
Thank
great.
you. Thank you so much. We're so happy to have you. There's water here if you need a water.
All right.
Alrighty.
Thank you so much.
darling.
Thank you. Thank you.
Please welcome the Vice Chair of the TARC Steering Committee, Dr. Rodrigo Morales. Dr. Morales is an Associate Professor at the Department of Neurology at the UT Health Houston McGovern Medical School. Dr. Morales has more than 18 years of experience in the field of protein misfolding diseases, specifically in infectious prions and Alzheimer's diseases.
Well, good morning and welcome to this session. As you saw in the program, we have a very packed session, a lot of talks now. But good, we will be knowing what each TARC site is doing, and I hope that this fosters collaboration. So please, for the presenters that are not sitting in the front row, we have reserved seats to save time. So please take your seats on the front. I also, to the audience, please no questions for the session. If you have any questions for the presenters, you can ask them in the breaks. And for the people that didn't time the presentations, at 4 minutes I will start waving you, so you stop. I want that we have a nice break before the Oscar Fisher lecture. So, well, we will start now. We will start with Dr. Bhavya Shah from UT Southwestern, and we will be hearing about transcranial focused ultrasound, next generation image-guided therapies of the brain. Dr. Shah.
Good morning, everybody, and thank you for the invitation to speak today. I'm going to speak on focused ultrasound and kind of give you an overview and some of the work we're doing with it with Alzheimer's disease. I have a couple of disclosures, Chimeric Medical Devices and Incytec, and you're going to see some patient videos. Patients have given their consent for the video. So today, transcranial focused ultrasound is FDA approved for treating essential tremor and Parkinson's disease. But the future is really in liquid biopsy, targeted drug delivery, and neuromodulation, and I'm going to be talking a little bit about that work. I think the slides are stuck. So everyone will recognize the MRI scanner in the background, and on that scanner bed, there's a helmet. The helmet has 1,024 phased array ultrasound transducers. Each ultrasound transducer will create its own ultrasound wave, and they will cross an intact skull onto a single point within the brain, and that is the focal point. So depending on how much energy you're using at the focal point, you can ablate tissue. At lower energies, you can change how individual neurons and neuronal populations behave, and you can also open a blood-brain barrier, which I'll be talking about. So for people who haven't seen someone who has essential tremor, this is a patient who has essential tremor. A lot of trouble with daily activities of living, writing, things like that. So immediately after focused ultrasound, this is the patient usually in recovery, and you can see that their tremor has immediately gotten better. Also, we bring our patients their favorite dessert, and you can see that the patient's able to eat and do some of the things they weren't able to do before. And then they're drawing spirals almost routinely, kind of showing off a little bit, and then sending us videos from that evening when they're drinking coffee and things like that. So like I was saying, focused ultrasound is a very dynamic technology. And if you use low-intensity focused ultrasound in combination with microbubbles, so these are gas-filled microbubbles that are injected into a peripheral vein and then exposed to focused ultrasound, these microbubbles will start to vibrate. As these microbubbles vibrate, they'll have mass effect on tight junctions and that push the blood-brain barrier open temporarily. So what are we doing in humans in Alzheimer's disease with focused ultrasound? Well, this is one of the current clinical trials. We perform an amyloid PET scan, and then we target specific regions of the brain for blood-brain barrier opening. And in this example, you can see an intraoperative images targeting the hippocampi. Also, we collect blood samples at various time points after BBB opening to evaluate if there's an increase in serum biomarkers of neurodegenerative diseases. But no one really thinks that this is going to cure Alzheimer's disease, right? So with my mentor and friend, Dr. Diamond, we've been working with a group in France who basically has a novel type of immunotherapy. So, human tau protein, human antibody, everybody will recognize that human antibody is pretty large. But there's certain animals, like Bernard here, who's an alpaca in France. When Bernard is injected with human tau protein, he'll make a nanobody. And then with our collaborators at UT Southwestern Radiology, Dr. Shanghai Sun, we can radio-label this with copper-64. So now I'm going to show you a P301S mouse. And on one side, you'll see that there's white contrast leaking out. The reason the contrast is leaking out is because gadolinium is too large to leak out of the intact blood-brain barrier. So the BBB has been opened on that side. And then if you inject that radio-labeled copper-64 in a P301S mouse that has human tau, you can see that it radio-labels it. But as you're looking at this image, you're probably thinking, how do you even know it's in the hippocampus? And so what we did was we registered the PET data to an MR data. And this is another animal kind of showing you the same thing. BBB opening, delivery of a copper-64 radio-labeled VHH nanobody to human tau, radio-labeling it in the brain. When you do this in wild-type mice, you really get no signal. So the second thing I want to talk about is knocking tau down. And so we can also do similar work where we deliver viral gene therapy across the blood-brain barrier. So this is an AAV9, and so many of you who work with viral gene therapy might say, well, AAV9 crosses the blood-brain barrier on its own. Why would you want to open it? Well, so on one side, with the red arrow, the blood-brain barrier has been opened, and on the other side, the blood-brain barrier is not opened. And you can see, even though AAV9 crosses, the efficiency is much higher with GFP expression seen on the resultant images. So another animal, P301S mouse, AAV9 co-encoded with GFP and anti-tau gene therapy. And what we're showing is that the side that we're targeted with BBB opening, you can see that there is a substantial reduction of MAP tau in that side of the same animal's brain versus the other side. So if I was going to tell you why I think that transcranial focused ultrasound represents a next generation tool, it's because it's incisionless. We don't give anesthesia and can see an immediate functional response. We can do targeted drug delivery. We can pair it with advanced functional and metabolic imaging, and we can do early disease stage modification. So thank you for the invitation again. I'd like to thank my lab and my mentorship panel, and I'll turn it back over. Thank you.
Thank you. So the next speaker is Dr. Elvis Cuevas from UTMB Galveston. And she will talking about sexually dimorphic blood-brain barrier responses in Alzheimer's disease.
Thank you. Thank you, everyone, for being here, and thank you, the organizer, for the invitation to present my work. I received my PhD in neurobiology at the UNAM. Then I moved to NCTR FDA as an assistant, as a visiting scientist. And now I moved to UTMB as an assistant professor in the I'm leading, at UTMB. Okay. Alzheimer's disease is the most common type of dementia, and there is more than 55 million people that are living with dementia worldwide. And the Alzheimer's disease is the most common type of dementia, and there is more than 6 million people in US. There are epidemiological studies suggesting that the women have higher prevalence of AD than men. However, there are no studies that evaluate the sex differences in the neuropathological or biochemical events. In this sense, it's highly recommended to include females and males in preclinical and clinical studies. There are some suggestions about the neurovascular unit and the blood-brain barrier plays an important role in these potential sex differences. Some of the explanation that can lead these sexual dimorphisms in the BBB and blood-brain barrier is the apolipoprotein allele, the estrogens, and the female obesity. So these events play a role in the BBB function. However, there are no sex-related BBB dysfunction that is not studied yet. Therefore, understanding the mechanisms that regulates the evaluating the role of the BBB in a sex-dependent matter, it will help us to understand and give a platform for develop better technologies for the women's health issues. Our hypothesis says then that the dysfunction of the neurovascular or the blood-brain barrier dysfunction is greater in women than in men. So for some years, we have been working in different models of BBB and Alzheimer's disease. And in this one, in this report, for instance, we reported that the amyloid beta, the toxic fraction of amyloid beta, produce a structural and functional dysfunction of the BBB. And these events were further evaluated in a model of transgenic model of Alzheimer's disease, of the familial form of Alzheimer's disease, where we can see a clear effect in the female groups. There was a decrease, a significant decrease in the occludin levels. And this decrease in occludin levels, which is a protein that regulates the tightness of the blood-brain barrier, there is a direct effect on the increasing of the permeability, suggesting that females somehow are more susceptible to vascular damage. These are some papers that we have been publishing regarding these issues, and it's like and I want to thank to all these people that is working in this. So then the long-term goals of the Neurovascular Research Lab is to evaluate the toxicity effects of amyloid beta and tau on the BBB associated to the hormonal changes. And we are planning to do this in a very comprehensive model of the neurovascular unit that is an organ on chips. And we are going to be evaluating markers of the BBB dysfunction for all the components of the BBB. We are planning to do as well animal studies in order to evaluate the BBB dysfunction for the onset and progression of the Alzheimer's disease related to sexual dimorphisms as well. We are planning to do the human studies as well. And in this, the endpoints that we will be evaluating is behavioral, such as memory, the BBB structural function integrity. Since this is in vivo model, we can use MRI and PET. We will be doing the CNS integrity and the neuroinflammatory pathways as well. By all these studies, we will contribute to the understanding of the sexual dimorphism changes in Alzheimer's disease, and ultimately we will help, or our approach will help to provide a significant information for targeting the BBB dysfunction. Thank you.
Thank you. So the next speaker is Dr. Karianne De Souza from Texas A&M University. She will talk about relationship between age-related cognitive impairment and circadian timekeeping.
Good morning. My name is Karianne De Souza. I'm over in Bryan College Station. And our lab studies the role and mechanisms of behavioral changes in mouse models. And so one of the preclinical signs, or one of the clinical signs of Alzheimer's disease, where a patient goes in to see a doctor, usually is memory and learning changes. And in normal aging, even before the diagnosis with Alzheimer's disease, we do see individuals that actually have cognitive impairment and are not necessarily an MCI patient. And some age individuals are actually cognitively unimpaired and normal. But again, as we already seen this morning, those cognitive changes happen pretty late in terms of being able to diagnose a person. And other behavioral changes might actually be beneficial in terms of detecting Alzheimer's, in terms of starting treatment and even just any kind of behavioral treatment or pharmacological treatment. And circadian dysregulation and sleep dysregulation is one of those things that are observed early. And immune changes are also observed with circadian dysregulation. And so what we wanted to do is we wanted to look at what were the timeline of these behavior changes, were there any links between circadian and cognitive changes, and is there a possible mechanism? In our case, we were looking at inflammation. And so we look at a normal aging model. So we use C57 mice, young, middle-aged, and aged, and we tested them with for circadian dysregulation with an activity chamber, and then further later we looked at memory and learning changes with a classical Barnes maze test. And what we did observe was that middle-aged animals, so at around 13 months of age, show circadian dysregulation. So this is, if you're not familiar with this type of actograms, this, as you go down, is at different days, and mice are nocturnal. They begin nervous hands, lots of shaking. They begin activity pretty set on when the lights turn off. But as animals age, and you can see here with the middle age, there is a significant variability on the onset of activity. And that happens pretty early. And of course, aged animals had already been shown to show this type of dysregulation. When we looked at the learning and memory dysfunction as a group, we see aged animals, so here is just the distance, and they get better over time. The aged animals as a group are significantly impaired compared to young, but the middle-aged animals are not. However, when we look at this cognitive index that we developed, which if you're interested, just come by our poster, number 1. It will tell you how we calculated this. We can see that some of the animals perform with the young and some perform outside of the young. Basically, we were able to model the cognitive variability observed in normal aging with humans and other types of mammal models. And by using this variable, we were able to look at the relationship between circadian and cognition, and there was a direct relationship between the variability and the cognitive dysfunction, which lead us to believe that there is a common neural mechanism of dysfunction that could potentially be targeted early in middle age, and then we could observe whether there is a difference later in cognition. As our current studies and future studies, we are looking at inflammation. Direct changes of circadian, so forced changes of controlled changes of circadian, do result in changes in immune and inflammatory activation. And we are looking at whether there is a direct way of determining causality between circadian and cognitive dysfunction. And we are also going to be looking further in the role of inflammation. So thank you very much.
So next, now we will hear from Miss Vanessa Young from UT Health San Antonio about sleep and cognition in Parkinson's disease with and without RBD.
Hi, good day, everybody. I would like to start by thanking the organizer and my amazing team for the opportunity to be here today to represent one of the many research efforts at UT Health Science Center, San Antonio. My name is Vanessa Young. I am a clinical research coordinator at the Glantz Big Institute with a background in psychology, rehabilitation, and a strong aspiration to become a neuropsychologist. What I would like to discuss with you today is sleep. Since we were children, we have been told that sleep is important for our brain and physical health. It bolsters our immune system and mental health, and it plays a pivotal role in mood, memory, and thinking. What's interesting is that as we age, sleep patterns and duration tend to change, and sleep problems become more prevalent, preventing us from getting a restorative night of sleep. Some people act out their dreams. They can kick, they can yell, they can even punch. And that is because they do not experience the normal sleep paralysis of their limbs during REM sleep. This disorder is called REM sleep behavior disorder, or RBD. And RBD is the most specific and predictive early symptoms preceding the onset of Parkinson's and dementia, appearing in some cases decades prior to an official diagnosis. However, not everyone with RBD will eventually develop Parkinson's or dementia. And that's why it's important to further explore the relationship between sleep performance and cognitive impairment among this population. Through a collaborative effort between neurologists, neuropsychologists, sleep technicians, and additional research assistants, this pilot study aimed at assessing sleep and cognitive performance among adults with early stages Parkinson's disease with and without RBD. How did we accomplish this? We administered health and sleep questionnaires, the MOCA, which is a widely used tool to detect cognitive impairment, an overnight in-clinic sleep study, and additional neuropsychological tests. In our preliminary findings, we found that those without RBD tended to score higher in their MOCA, and they also registered a higher percentage of REM sleep when compared to those with RBD. At this stage, we did not detect any statistical significance in the predictor of age, gender, and educational level. However, what caught our attention was that none of those with RBD enter stage 3 sleep. We will continue to analyze our data to explore the association between sleep and cognitive performance between those two groups and see how those two variables intertwine, in addition to investigating stage 3 sleep as a potential predictor for impacting sleep quality and cognitive performance. I don't want to be misleading. Our study had a very small sample size. We only had 20 participants, which obviously hindered generalizability of our findings. However, it paves the way for future research study to understand whether the results are reproducible and whether we can speak of both clinical and statistical significance. Because stage 3 sleep, also known as slow wave sleep, plays a critical role in memory consolidation, of high interest is to explore stage 3 sleep in relation to cognitive impairment among adults with Parkinson. Well, excuse me. And we will continue to analyze and see, because irregularity with slow wave sleep have been associated with increased amyloid beta, which is metabolic waste, and is the main component of amyloid plaque in adults with Alzheimer's. I believe that prevention is better than intervention, and continue to investigate how sleep and cognitive performance relate may aid in the development of novel multimodal treatment option to slow down and prevent Parkinson's disease and other related dementias. Thank you so much. If you'd like to discuss with idea with me later today, I am a poster number 66, and this is our amazing team. Thank you.
Now we will have Mr. Celso Catumbela from UT Health Houston. So Celso.
Well, good morning. My name is Celso Catumbela, and I'm a PhD candidate in the lab of Dr. Rodrigo Morales at UT Health Houston. Today I just want to give you some insight into the different lines of research that we have ongoing. And one of the focus of our labs is to look into how events in the periphery contribute to the pathology of Alzheimer's disease. And we look into peripheral events such as the dysfunction of tissues in the periphery, as well as just abnormal activity of immune cells in circulation. And so the focus of my PhD thesis has been on understanding how liver dysfunction alters amyloid pathology. And what I did was I conducted a drug-induced liver damage for 12 months, and I submitted what I used were wild-type and AD mice models. And what we found was that indeed, liver damage does contribute to the pathology of Alzheimer's disease, worsening it, and that this occurs in a sex-dependent fashion, with females showing much worse pathology at late ages following liver damage compared to males. And what this type of work really will sort of help contribute to is that it helps us understand the pathological crosstalk between not just the brain and the periphery, but also between Alzheimer's disease and liver disease. And this is important because both of these diseases are expected to increase in incidence over the coming decades. So their combined risk to public health is something that we need to take into consideration. Let's do the clicker. Sorry. Okay, sorry. Yeah, so now we're also, another line of research in our lab is into how pathogen-induced infections affect Alzheimer's disease pathology. And here we are working with collaborators at UT Health Houston as well as abroad. And what we're doing here is taking a two-pronged approach. And one involves using animal models, where we submit these animal models to either peripheral or cerebral infection. And then at varying stages of disease, we examine hallmarks of AD and then link them to either, to see whether the peripheral or cerebral modes of infection alter them in distinct fashion or similar fashion. Now, the second approach that we do is looking at using human-derived samples, in particular CSF and plasma, from patients with a history of either sepsis, meningitis, or COVID-19. And what we do here is we then submit these samples to biochemical evaluation to look at different hallmarks of different cellular molecular markers of AD pathology, as well as some that have been thought that could be involved in AD pathology. And here we do a similar thing where we look at the overlap between how these different modes of infection affect Alzheimer's disease hallmarks and whether they are distinct from one another, and ultimately how they go on to, we try to predict how they might affect Alzheimer's disease pathology. So for subsequent studies that will use animal models instead. Now, one other line of research in our lab involves just trying to understand why the clinical manifestations of Alzheimer's disease vary so widely between patients. Now, we and others have hypothesized that AD is not a single disease, but rather a spectrum. And what we believe may underlie this spectrum of diseases is observed in just the type of amyloid plaques that you see in patients. And so what we're wanting to do here is to look and to isolate different types of plaques from patient brains and then characterize the peptides of amyloid beta that are involved in these different type of plaques to see if they are distinct from one another or not. And in this same concept, we also want to take these different types of plaques and inject them into different mouse models to then see whether or not the pathology, how the pathology progresses in these different mouse models and how they are linked to the types of plaques that we're injecting. Now, this is not a novel concept, but we are trying to simply explore this concept as well because we believe that ultimately this will help us personalize diagnosis and treatment options a lot better and just get a better sense of the mechanisms that underlie Alzheimer's disease. Now, finally, I would be remiss if I did not mention the diversity of dementia research that is going on at UT Health Houston. We have not only the work that I've already mentioned with our collaborator, Dr. Tatiana Baricello, looking at how the impact of COVID-19 on AD, but also we have other researchers looking at blood-based markers, blood-based markers for AD, as well as others who are elucidating the mechanisms of AD pathology as well, and some who are looking to expand the therapeutic strategies for AD. Thank you.
All right. Now we have Dr. Matthew Moulton from Baylor College of Medicine talking about glial lipid droplet formation is neuroprotective and requires AD risk genes.
Thank you to the organizers for giving me this opportunity to preview some of my work in the Bellin Lab. I want to tell you today about our work that has used model organisms to identify a glial lipid droplet pathway that is neuroprotective against oxidative damage and requires AD risk genes. Mitochondrial function wanes through age and during diseases like Alzheimer's disease, leading to the production of oxides, including those termed reactive oxygen species, or ROS. We've demonstrated using our models that ROS production activates a lipogenic pathway in which these newly synthesized lipids are peroxidated in the presence of ROS. Peroxidated lipids are highly toxic to the cells and must be rapidly dealt with. One method by which this occurs is by shuttling these cytotoxic peroxidated lipids to neighboring glia, where they can be processed into lipid droplets and sequestered there. We've identified this glial lipid droplet phenotype using several models of rare diseases that cause mitochondrial dysfunction in neurons. And using these models, we have demonstrated that this lipid droplet production is neuroprotective. When lipid droplet production is inhibited or during periods of extended mitochondrial stress and ROS, neurodegeneration rapidly ensues along with glial cell death. We argue that so lipid droplets have also been identified in human studies, including in AD, and we argue that this process of lipid droplet accumulation is conserved, and it's important to understand why this process occurs and how it can be utilized to prevent neurodegeneration caused by oxidative damage. We've undertaken these studies in model systems to identify genes involved in this lipid droplet pathway, and you may be immediately familiar with many of these because they overlap with AD risk loci. One important key feature of our study is that we've identified a cell type specificity for each gene of interest. For example, ABCA1 and ABCA7 are required. We've demonstrated specifically in neurons, but not in glia, consistent with their role in transporting lipids, whereas other genes like endocytic genes and the ApoE gene are required in glia to take up lipidated apolipoproteins. So this is a powerful function of our system where we can identify not only genes that are important for this pathway, but in which cell type they are required. And we've confirmed these findings in mammalian studies as well. We've also demonstrated interactions between ROS and amyloid beta and the lipid droplet pathway. A-beta 42 expression in the fly causes severe neurotoxicity and can be exacerbated by the presence of ROS. We've also demonstrated in a mammalian model that ROS can exacerbate amyloid phenotypes, including elevating the number of amyloid plaques present and the size of these plaques. We hypothesize that that the lipid droplet pathway can actually help uptake amyloid from the extracellular space because amyloid interacts with ApoE, the apolipoprotein receptor LRP1, and is a lipophilic molecule. So as you upregulate the production of lipid droplets, you can potentially clear A-beta from the extracellular space. So taken together, the data that I've discussed today implicate glial lipid droplet in the protection of neurons from the adverse effects of both reactive oxygen species and amyloid beta. We've identified multiple risk factors for AD that all function in this glial lipid droplet pathway, suggesting this could be a potential therapeutic target in the future to protect against ROS-induced and amyloid-induced neurotoxicity. Our current efforts in the lab are aimed at generating humanized fly models where we replace a fly gene with a human cDNA, and we can test the wild type and variants of that cDNA in an in vivo model. This allows us to assess the consequences of AD risk variants, coding variants that might be important for the disease. I want to thank the people listed here and all those who support and fund our efforts, and conclude there. Thank you.
Now we will hear from Dr. Bonnie Scott from UT Austin Dell Medical School about the clinical utility of cognitive variability in dementia evaluation.
Thank you. Good morning, everybody. Like you said, my name is Bonnie Scott. I'm a clinical neuropsychologist and a new assistant professor of neurology here at UT Austin. And I recently completed a 2-year postdoctoral fellowship that was funded by TARC, so thank you, TARC. And during that time, I've been working with Dr. Robin Hilsbeck and Don Royal in examining the clinical utility of cognitive variability, or what you might consider performance inconsistency on our cognitive tests, and how, looking at this variability in our standard neuropsychological measures could help us actually identify individuals who might be at greatest risk for incipient declines in cognitive and functional independence. And so, consistent with prior work in this area, we found that increasing variability is associated with important clinical outcomes, including, as I noted, declines in cognition and functional status, as well as increasing morbidity and even mortality. And so what we did is most recently, we've looked at the construct validity and the clinical utility of different IIV metrics in the TARC Hispanic Longitudinal Database. And we looked at individuals who were cognitively normal with and without subjective cognitive decline, and our folks who had mild cognitive impairment. And I have a lot of data to share with you all that I obviously can't cover in a short amount of time up here, but I'm going to put in a plug for my poster. It's poster number 37. I'd love to share these details with you in a moment, or this afternoon. But I'm going to go over just some broad strokes, main highlights. So first, we know that cognitive variability, they don't auto-advance. Oh, they do. Okay, there we go. So first, we know that increasing cognitive variability is associated with important clinical outcomes. And it might be related to declines in frontal executive abilities. We can look at different IIV metrics. So we've examined them across all tests within a given battery, between domains, your traditional sort of cognitive domains like attention, memory, language, and just across all tests. And so we found that in general, they're all associated with subsequent declines, but they also show some unique associations with each other. First, suggesting that they might be tapping into different pathophysiological processes and with different blood-based biomarkers of neuroinflammation and microvascular dysfunction. And so we still need to replicate these findings in an independent sample. But overall, looking at these variability indices, in addition to data that we're already collecting as part of our standard neuropsychological evaluations, might help us identify individuals who are at the greatest risk for subsequent decline at the earliest possible stage when preventative interventions might be most effective. Thank you.
Now we will hear about the role of vitamin A in Alzheimer's disease from Dr. Josh Lawrence from Texas Tech University.
Hi there. I'm Josh Lawrence, I'm at Texas Tech University Health Sciences Center. I recently received funding for the role of vitamin A in Alzheimer's disease through 2 NHR01 grants. My co-Is are Drs. Bailu, Panarov, and Manzak, and I have 3 team members today here. Ashley Hindle, who's a postdoc, and then Nicholas Wojcicki and Matt Buxton, who will be presenting posters. They're medical students. So, I advance. Is this an auto advance? Thanks. Okay, so the overall purpose of my first NIH-R01 grant is to test the hypothesis that vitamin A is depleted in Alzheimer's disease. It builds on this scientific premise in the literature that the bioactive metabolite of vitamin A is all-trans retinoic acid. It has a dual role in which it's an antioxidant, but also it stimulates through retinoic acid receptors an upregulation of alpha secretase, thereby avoiding amyloid beta. So it's an exciting idea that I'm going to work on. This is a cross-disciplinary study that spans behavior, circuit analysis, molecular assays, and single-cell transcriptomics. Okay, so we're working on kind of a 2-pronged approach, looking at both the human transcriptome, the vitamin A transcriptome, through publicly available data sets, as well as in transgenic mouse models. We use the RARE-LAC-Z mice. And just to give you an idea for the overall approach that we're taking is that, Retinoic acid receptors they're hormone-like nuclear receptors that induce transcription by binding to retinoic acid response elements on retinoic acid-sensitive genes. And so we expect to reveal vitamin A deficiency or retinoic acid deficiency by the impairment of transcription of these retinoic acid-sensitive genes. So far we've looked at hippocampus of RAR-relax-Z mice, and we see that the hippocampal dentate gyrus plays a really important role in retinoic acid-induced transcription, and we expect that to be an area that we'll focus on. Okay. So our initial perspective is that we're taking this multi-pronged approach. We're looking at vitamin A deficiency and sufficiency in Alzheimer's disease, both human and mouse models. We're trying to expand by looking at other publicly available data sets. And just an overview of the 3 posters we have. So glucocorticoid signaling is our top vitamin A sensitive pathway, implies connection between stress and diet. We're very interested also in upstream modulation, so looking at the liver and brain connection because vitamin A is stored in the liver. And then finally, we're interested also in the gut-brain axis and the role of vitamin A in sustaining, preventing gut permeability. I just want to give you kind of some overall milestones at T2HSC. So Dr. John Bertelson, who I met yesterday, he's the new TARC PI for the Lubbock site. There's a lot of really good activity. So in addition to my 2 NIH grants, there's many more NIH grants funded, a lot of them through Dr. Hemachandra Reddy. So there's over $5 million in active NIA grants in the year 2022. And in addition, there's a lot of good productivity in terms of publications, 34 publications from 2022. And then just recently, in November, we reestablished the West Texas Society for Neuroscience chapter. And so that's going to be an exciting area of expansion to regional universities in the future. In addition to the 3 posters that I have, there's 2 other posters through a collaboration between Dr. Singer's group at TTU and Dr. Neugebauer's group, who is based in the Garrison Institute on Aging. So thanks very much.
Now we will hear from TARC studies of AD-related peripheral markers of mitochondrial dysfunction by Dr. Nicole Phillips at the University of North Texas Health Science Center.
Great, we're going to jump right in. My name is Nicole Phillips. I'm an assistant professor, as was just said, at UNT Health Science Center. So first, I'll just give a little bit of an overview of our team and our lab's main focus. Dr. Courtney Hall, Dr. Danielle Reed, and Isabel Gorham, shown left to right here, are students, past or present, who have generated the bulk of the data that I'll be talking about today in these projects. What we're really interested in is mitochondrial function and how we can look at mitochondrial DNA specifically in the periphery as an indicator of dysfunction in the brain. That leads us to the primary TARC-funded project right now, which is looking at isolating neuronal enriched extracellular vesicles from peripheral blood plasma. The idea here is that these biological packets are released from neurons, and we can isolate those from plasma using targeted capture and kind of get a glimpse into brain function and pathology from afar. Courtney Hall is the primary researcher who's been developing these protocols and methods, hard at work doing so. It's difficult from small to obtain enough nucleic acid material from these relatively low abundant molecules in the periphery, but we've successfully, I'll hope to show you, been able to do so. So the 2 main research questions here, one is, can we detect early signatures of brain pathology in the periphery looking at the cargo of these packets, these exosomes specifically? We're sequencing microRNA and also quantifying and sequencing mitochondrial DNA. Secondly, we're interested in the longitudinal nature of those molecules, looking at 2 different time points, and also to see if there's population-specific effects. So the overall strategy for the design here is we're looking at both Mexican Americans and non-Hispanic whites from the TARC cohort. We've obtained blood samples. We have optimized the protocol for isolating those neuronal enriched populations here, And then again, we've developed the pipeline for microRNA sequencing using Illumina platform, as well as quantification of mitochondrial DNA from the exosomes that originated from neurons, again, in the periphery. Let's see if we'll advance. Again, I just mention again that Dr. Courtney Hall is the one who's optimized these methods. So shown here, the main question and the primary findings so far have really been technologically proving and showing that we are successfully capturing the CD171 population, which is highly likely to have originated from neurons. And again, from 500 microliters of plasma, we've shown that we've been able to successfully quant the mitochondrial load in these molecules, or these vesicles, as well as sequence the microRNA cargo. So it's a highly sensitive method that we've been working to develop. In preliminary studies, we've already identified that the microRNAs that we've obtained from the neuronal enriched population do show enrichment for microRNAs that are relevant to mitochondrial function. So we have early indicators that these might be informative of mitochondrial function in the brain. And we are currently pushing through a high throughput protocol to analyze the bulk of these samples, which is approximately 175 in each group, again, looking at the plasma. So I'll shift directions just a little bit here to talk about a couple other studies. Dr. Danielle Reed recently published out of our group looking at oxidative damage in the molecules that we were sequencing and obtaining from peripheral plasma and peripheral blood cells. And we reported that Mexican-American females had a very distinct elevation of mitochondrial DNA oxidative damage when detected in the periphery that we did not see in non-Hispanic whites. And it was suggestive to be associated with cognitive function also in these individuals. There are other key findings from our group. Isabel Gorham, a master's student in my lab currently, this is not published yet, but the manuscript's in preparation, looked at not damage, but abundance. So we're looking at quantity of mitochondrial DNA in the cellular fraction as well as the cell-free fraction of blood from the TARC cohort. And interestingly, we saw some population-specific effects where we saw, for example, association with cognitive function only in Mexican Americans in the Buffy coat portion. So just to kind of put it all in perspective, we know that mitochondrial function is an early hallmark of Alzheimer's disease, and we're really interested in developing these methods for biomarker development, but also for potentially getting an insight into brain pathology so we can develop more targeted therapeutics, stratify groups by risk more effectively, and again, hopefully be able to monitor interventions and develop population-specific interventions as well. So thank you.
Okay, the next talk is Stiff and Disruptive Brain Vasculature in Alzheimer's Disease, Impact of Blood Pressure Dysregulation by Dr. Jesus Melgarejo at the UT Health Rio Grande Valley.
All right. Hello, everyone. Thank you very much for giving me the opportunity to present this research work on behalf of UTRUV. I am Jesus Melgarejo, and I am a medical doctor from Venezuela. I obtained my PhD in biomedical science at KU Leuven, Belgium, and I recently joined UTRGV as assistant professor in neuroscience to work alongside Dr. Gladys Maestre. My role within the institute is to understand how the systemic vasculature impacts the brain. And one line of research is a stiff and disruptive brain vasculature in Alzheimer's disease, impact of blood pressure dysregulations. Nowadays, when we talk about Alzheimer's disease, it's not only about accumulations of beta amyloid plaques or tau tangle proteins in the brain. There's also vascular pathogenesis in the disease that one of those is aging of the brain vasculature or cerebrovascular aging, which typically present as arteriosclerosis, and in both conditions, they lead to impaired blood flow and supply to the brain, promoting the development and progression of Alzheimer's disease. But when we talk about cerebrovascular aging, we often forget that it's concomitant to aging in other vascular systems. And this is a part of the puzzle in the vascular pathogenesis of Alzheimer's disease that we want to understand. So our aim is to look into blood pressure dysregulations as one part of this aging of other systems. And why we need to look into blood pressure dysregulations. If I take your blood pressure now and I take it again in 20 minutes, it's going to be different, and that's okay. And if I measure it over 24 hours, there's going to be a normal variability, and that's also okay. But what we have been able to document is that there are certain pathologies and conditions in which, although individuals they have a normal blood pressure or a similar blood pressure as healthy participants, their blood pressure changes more. And with greater variability comes more drastic peaks and drops in blood pressure. But especially when blood pressure goes down, as you can see in the red dots, we are hypothesizing that this is where the damage occurred. And one of these hypotheses that we're managing is because there is a reduced blood supply and impaired flow to distant organs, including the brain. But wait a moment. When we look into the association between blood pressure and the brain, we also documented that it's modulated by cerebrovascular aging. So we know that the higher the blood pressure, the higher the burden of microvascular damage in the brain. That's true. But if you include into that equation cerebrovascular aging, you're going to see that there are certain components in the blood pressure that they are going to be different. And that's the case of diastolic blood pressure. Let me give you an example. The more stiff the cerebrovasculature is, the lower the diastolic blood pressure. And with this comes a lower diameter in the blood vessel, lower diastolic flow, creating a hyperperfusion state in the brain tissue, promoting, for example, Alzheimer's disease. So all these hypotheses, we have been testing them by conducting baseline and follow-up studies. We have used data from population-based study, and we were also able to build up case control studies matched by age, sex, or other clinical parameters. And we want to use the same approach in our current project. And the idea is that we're going to be able to answer the gap, one of those. What is the impact of blood pressure dysregulations in the brain in the presence of cerebrovascular aging? If we understand these two vascular components in the pulse of Alzheimer's disease, in order to do this, our aim is to study the connection, the interaction between the two systems to have a better understanding of aging-related disorders. And why? Because what we want to have is a natural course of aging. What happens is that in the presence of cerebrovascular aging, and on top of that, you have blood pressure dysregulations, this is going to lead to a worse impaired brain functioning, and with this, a greater risk of Alzheimer's disease. So if we are able to understand how these two vascular systems interact, what we're going to be able to do is to avoid the consequences of these conditions. We want to avoid white matter hyperintensities, lichens, or microbleed. And because with this, they're going to also lead to a susceptible brain to develop Alzheimer's disease. And that what we want to achieve is a natural course of aging. So in our project, the future directions is to test novel hypotheses. One of those is that sporadic drops in the blood pressure combined with cerebrovascular aging, they're going to lead to impaired blood flow and supply to the brain. The actions with our findings that we expect is that we recognize that cerebrovascular aging is important to assess Alzheimer's disease, and our aim, although it's a general one, I will say, I think it's one we will share, is that towards a better vascular aging, we hope that we can prevent Alzheimer's disease. So thank you very much for your attention.
Okay, now we will hear from Dr. Christian Lobu, I hope I pronounced it right, from UT Southwestern, about Alzheimer's disease and related disorders following traumatic brain injury.
Thank you, and it is such a pleasure to be speaking in front of an esteemed group of colleagues. I am a clinician scientist at UT Southwestern Medical Center, and an often asked question we get from patients and families is whether or not their concussion decades ago may be related to the memory loss they're experiencing now. And a part of the focus of our lab is really try to answer those questions and understand what are the long-term effects of traumatic brain injury. Now, TBI, or traumatic brain injury, ranges from mild severity to being moderate and severe. And while it's widely accepted that the moderate severe TBI is a significant risk factor for later developing Alzheimer's disease, mild TBI is still debated. Approximately 7 to 10% of individuals go on to develop dementia later in life following any TBI. And the goal of our lab is to understand what places these individuals at risk, and then second, to understand knowledge about the diseases to identify new treatments. Now, there are several theories about why TBI might contribute to Alzheimer's disease. Foremost is that TBI might damage the cells in the brain, causing cell loss and accumulation of amyloid and tau, the proteins involved in Alzheimer's disease. And others have posited that maybe TBI disrupts the flow of cellular processes in the blood, causing accumulation of those proteins. Now, we've had discussions in the lab about whether Alzheimer's might actually be related to the acute effects of TBI, or instead, if it might be related to the consequences happening after TBI, such as the onset of medical conditions like seizures, or someone becoming impulsive and starting to use drugs. So, a recent project in our lab sought out to answer this question. Among a large sample of patients with moderate severe TBI, we examined what predicted a significant decline in carrying out cognitive activities out to 20 years after injury, looking at the multiple features of TBI, but also those medical conditions that could come up and actually explain some of the risks, like having seizures, using drugs, in addition to the changes in social determinants of health that can emerge after a TBI itself. Now, what we found is that there are actually only 3 predictors that were significant. Most of the associations actually were with when the injury occurred and severity, such as the number of days one had amnesia. So with data supporting that the acute features of TBI appear to be the most important in risk for cognitive decline, much of our work is focused on examining or understanding what role does TBI play in developing Alzheimer's disease. So does it impact the course itself? And so illustrated here, we've looked at and found that a history of TBI resulting in loss of consciousness has been associated with an earlier onset of Alzheimer's disease, as well as frontotemporal dementia, and even the prodromal stage of mild cognitive impairment. Now, we don't know why the association occurred, but we suspect it may relate to having more proteins involved in Alzheimer's disease by having a history of TBI. And as a result, a recent pilot study that we conducted, is hot off the press, looked at the proteins of amyloid and tau in spinal fluid in those that had Alzheimer's disease, and whether there are differences based on having a history of mild TBI. We didn't see anything with amyloid, but we saw a statistical trend and actually a large effect size for having higher tau, phosphorylated and total tau. And so just pulling all those pieces together, this is currently how we think TBI relates to Alzheimer's disease in our lab, that for some individuals, when they sustain a TBI, they have a higher, or they accumulate some proteins involved in Alzheimer's disease, perhaps tau-related cell loss. And as they age, when they go on to develop dementia, they cross over the threshold earlier, having an earlier onset of symptoms compared to those individuals who don't have a history of TBI. And so at this point, with a recent K award from the NIA, we're seeking to build upon our prior work and first hoping to learn whether mild TBI specifically is associated with having higher Alzheimer's proteins packaged within blood in those with prodromal Alzheimer's disease, and then using novel state or electrical stimulation to learn whether there may be a greater disruption of circuits involved in memory functioning by having a history of mild TBI. We are also using electrical stimulation, examining whether it may be or could enhance plasticity of damaged brain circuits to potentially improve cognitive deficits in those with prodromal Alzheimer's disease. Dr. Jung, who's pictured here, and a colleague and friend, is helping us lead the project, and we are excited that TARC is sponsoring it. We'll be using neuropsychological measures, but also EEG techniques in order to understand whether there may be a new or novel viable treatment for Alzheimer's disease. Thank you.
The title of the next presentation is Game Plan for Care Online Translation of Reach to Intervention by Dr. Yin-Yong Cho from Texas A&M University.
Hello, my name is Jin-Myung Cho. I'm a research investigator at Baylor Scott & White, and then adjunct faculty member at the Texas A&M School of Public Health. As a gerontologist, my research focuses on improving health and well-being among older adults and caregivers from different settings. So I've been working on the implementation and then evaluation of a community-based intervention program for older adults and family caregivers. So this presentation is about our current NIA-funded project, Game Plan for Care, which is an online translation of a REACH intervention program for caregivers for dementia patients. Lessons learned from the implementation and evaluation on intervention program in the community settings, where there are still barriers in the delivery of intervention programs or services for dementia caregivers. So sometimes, community organization has some personnel or resources, which may not cover the systematically organized intervention components. So we are thinking, how can we deliver a little bit more accessible evidence-based program to overcome these kinds of barriers and maximize outcome improvement? So what if we can deliver evidence-based intervention program through online? So we developed a web-based platform called Game Plan for Care. The purpose of this NIA-funded project is to create online family caregiver support system by applying technology to an existing evidence-based program. So collaboration effort from multi-organization is a foundation of this project. So first aim of this project is develop an online delivery system by adapting existing reach to intervention materials and conduct usability testing of the system. So the figure on the right side shows the development process of the delivery system. Then after intensive working with user interference and user experience experts, the system finally produced. And then 31 caregivers recruited from community-based organization in Austin and Temple area are involved in usability testing. So we ask them to complete the task about the technology and contents of the system. Then participants expressed largely positive reaction to the system and excited for the supportive contents and the resources of the system. And then second aim is to conduct actual intervention through a randomized clinical trial. The black and white figure shows the study design. After receiving referrals from the community-based organization in North and Central Texas, we conduct initial assessment for the family caregivers who enrolled in the study, and then assign them to either intervention group, which is a game plan for care group, and then the other group for a control group is the resources for a care group. So compared to the control group, intervention group receives more reminders and calls, as well as the participants have full access to the intervention contents in the system for 6 months. So far, the enrollment completed late last year. Then almost 150 participants completed 6 months follow-up assessment. And then we are expecting the completed outcomes for entire enrolled study participants will be available summer this year. Then we expect the successful completion of this project will be creating an evidence that the use of technology can ease burden of dementia caregiving, as well as reduce the cost of the intervention. Thank you.
Now, Dr. David Hunter will be talking about clinical research at UT Health Houston.
Hi, they skipped over someone. I'm David Hunter. I am a behavioral neurologist at UT Houston. I've spent my whole career at UT Houston, though I'm originally from Austin. And I was visiting my grandmother, who's 91 and has MCI last night. And she was very overjoyed that I was going to give a talk at the real UT. And I actually am honored to be here as well. It's my alma mater, and I haven't ever spoken here as a faculty before. It's exciting. So I might have missed the assignment. I don't have a single project to talk about. I just wanted to fill you in very briefly on what all we're doing in our Neurocognitive Disorders Center. That's Dr. Paul Schultz, my mentor, and a gentleman that was the first patient in Texas to get Aduhelm. So there's the two of us, and then we also recently hired a nurse practitioner who's a fluent speaker of Spanish. And one of my goals for the new year is to start enrolling Spanish-speaking patients in some clinical trials, because we're already doing a decent job at the clinical side, but we haven't been able to enroll people in the Spanish language yet. So that's one thing I'm looking forward to. We have a several hundred new patients every year. They come from all over Houston and surrounding areas, very diverse population. How can I advance the slide? There. Oh, I skipped one. So, like I said, I don't have grants or a single project that I work on. I mainly help to operate clinical trials for sponsors as well as other people in the department. So these are a selection of our sponsored Alzheimer's trials. We have all sorts, phase 1 and 2, or sorry, 2 and 3. Most of them have been anti-amyloid trials, and as I'm sure all you know, they come and go very quickly. So sometimes they end abruptly, and sometimes they come along abruptly. So currently we're in those last several on the end. It's both symptomatic and pre-symptomatic. These are just a sample of some of the investigator-initiated things we're involved with. We collaborate with other folks in the neurology department, folks in the psychiatry department at UT, places at people at Rice, as well as other institutions. So some highlights, for example, would be what we're doing with MEGS, electroencephalography. Another goal going forward, though, will be to work more closely with our vascular neurology colleagues. As you may know, UT Houston is very well known for its stroke department. They have tons of resources, and we ought to take more advantage of them and see how it relates to cognition. Both the entire department, including a lot of our patients, are enrolled in a biobank currently. We have blood and CSF samples on tons of patients, so that's another area where we're moving forward to in the near future to better utilize that data. So that was a whirlwind. These are the folks I work with. We have about a dozen study coordinators, so large program. Even though there's not too many faculty, we are looking to recruit more faculty if you know anyone in behavioral neurology. All right.
Thank you. So now we will have Dr. Roy Lin from the Baylor College of Medicine. And the title of the presentation is Cerebro-Hippocampal Connectivity in Mild Cognitive Impairment and Mild Dementia Due to AD.
Thank you. Good morning, everyone. Thanks, Tox, for the opportunity for me to talk about the project Cerebello-Hippocampal Functional Connectivity in MCI and Mild Dementia Due to AD. I'm an assistant professor of neurology in Alzheimer's Center and Parkinson Center of Baylor College of Medicine. So in neurodegenerative disorders, there is a hypothesis called network degeneration hypothesis. Basically, it means that the abnormal molecular and pathological features spread along a certain brain network. For example, from this illustration, the side of the triangles represents the brain network. And another important concept for the network degeneration hypothesis is that the less affected area could potentially serve as a compensatory effect to the already damaged brain network. So in brain, there's this small brain called the cerebellum, which is less affected in the already damaged Alzheimer's disease brain network. And traditionally, cerebellum was taken as a motor function organ. However, it's been very well established in the past 15 years that the cerebellum can contribute or modulate some certain cognitive and behavioral system called CCAS. And the most important thing is that the large brain and the small brain talks to each other via the cerebellar circuits. As you can see from this right lower quadrant figure, the cerebellum modulate or contribute the behavioral and cognitive function through this brain network. So the cerebellum is a potential target to compensate the already damaged brain network of the Alzheimer's brain. So in our preliminary study, we analyzed data from the ADNI. As you can see from the bar figure, from the cognitively normal to MCI and to Alzheimer's disease, there's a stepwise reduction of the cerebellum volume. However, very interestingly, in MCI stage, the pre-stage of dementia, the larger the cerebellum is associated with the worse cognitive function. So instead of smaller cerebellar size, right? So does this increased cerebellar size further reflect a compensatory effect from compensatory size increase from the cerebellum, or does this increased cerebellum size really serve as a compensatory effect to the already damaged brain network? That is the reason why we are conducting this study. And as you can see from the right upper figure, the cerebellar atrophy has been identified in multiple different neurodegenerative disease. In Alzheimer's and frontotemporal lobe dementia is also included. So these recruit numbers are from 2 weeks ago. Now we have 2 control, 3 AMCI, and 3 mild AD. Our target is 15 study participants for each group. So we'll place the region of interest, using functional MRI, we'll place the region of interest in hippocampus and also the cerebellum to study the functional connectivity between the cerebellum and hippocampus in 2 ways. So our hypothesis is that given that MCI and mild AD are still early in the disease stage, so there's a chance that we will see the enhanced or increased connectivity in MCI and mild AD. However, alternatively, maybe we will see a transiently increased functional connectivity in MCI, and later in the mild AD stage, the connectivity become decreased. And we're also very interested in the clinical imaging correlates. So our cognitive and behavior measures include ADAS-Cog, MoCA, MPI, and CDR to quantify and measure the cognitive and behavioral function severity. So this study will serve as a proof of concept study to further investigate the compensatory mechanism in Alzheimer's disease brain network. And the functional connectivity between the cerebellum and hippocampus could serve as a potential imaging biomarker, which could be especially useful for neuromodulation in the future. And of course, using the same principle, we can broadly apply it to other related dementia, such as dementia with Lewy body. Thank you.
Now from UT Austin Dell Medical School, we have Dr. Minshu Shang, who will talk about closed-loop brain stimulation as a potential intervention for cognitive decline.
Hi everyone, I'm not a doctor yet. I'm a PhD student at UT working with Dr. Jose Mian and Robin Hilsabek. Today I'll just give an introduction about our newly ongoing project that is called closed-loop brain stimulation as a potential intervention for cognitive decline. Okay. So the purpose of the project is based on previous literature work, 2 main ones. One was where people tried delivering transcranial magnetic stimulation to see the effects of it in improving working memory. And it has shown that TMS is able to improve working memory that lasted for up to 15 days. And also there was another fundamental work where they showed that you can use video games on older people to elicit cognitive function enhancement that lasted for 6 months even after the intervention. So based on these 2 studies, we hypothesized that by delivering a TMS that is closed loop controlled by a neural correlate of anticipation called the contingent negative variation, we'll be able to see deliver like a more efficacious brain stimulation protocol non-invasively. So this closed loop stimulation will rely on 2 factors, which is first we'll rely on a theta burst stimulation, which is a variant of repetitive TMS based on the concept of theta gamma coupling. And the stimulation will be delivered in after like be triggered by contingent negative variation decoder. I'm part of a brain computer interface lab, so It is a neural correlate that is recorded from EEG, which is an event-related potential delivered by two stimulus paradigm. So to share the findings that we have got so far, we have developed an interface, a 3D game that elicits CNV potential. So, sadly the video is not turning on, but it's like a driving game where people are given like a flanker task and then are supposed to have this in mind and later elicit their response when they are supposed to, since CNV is a potential that is very time locked. And we have so far confirmed that open loop TBS is able to modify the amplitude of the CNV. So on the right figure, we are showing that it was indeed able to modulate upregulate the amplitude of the CNV after delivering intermittent theta burst stimulation. So the perspectives towards this project is that we hope this will serve as like a milestone towards developing efficient, non-invasive neurostimulation, and also that it'll serve to kind of elucidate the relationship between neural correlate of cognitive functions and corresponding therapeutic benefits. And just excited that we have moved on to, we are gonna try this intervention as it is kind of finished to MCI patients which is our kind of like target population. Thank you.
Okay, so now Ms. Ann Abraham Daniel from the University of North Texas Health Science Center will talk about the role of methylation in risk for cognitive impairment in Mexican Americans.
Hi, my name is Anne, and I'm a PhD candidate nearing completion at UNT-HSC. So coming from the lowlands of Scotland, I had limited knowledge regarding Mexican American population, and this project helped me understand the health-related complexities this group faces. The Mexican American population is the largest aging ethnic minority group in the US, with a unique susceptibility for cognitive impairment. Therefore, further investigative research is required in this population. An influencing factor might be methylation, which is the addition of a methyl group to the cytosine base of DNA. And these can occur specifically at regions called CPG sites. And there are a variety of factors that can drive this, such as environmental factors that are diet and lifestyle. So this may explain some of the unique susceptibility that Mexican Americans have for cognitive impairment, as lifestyle factors can vary from one ethnic group to another. Our aim was to discover if there were differences in methylation between those individuals that are cognitively impaired versus normal controls among Mexican Americans and non-Hispanic whites, and to compare any differences in terms of the results between ethnicities. A total of 551 TARC participants were selected for the study following data quality control, and they were stratified according to those that were either cognitively impaired or those that were normal controls by ethnicity. DNA was obtained from peripheral blood from participants and genotyped as well as typed on the Illumina EPIC chip array that assesses over 850,000 CPG sites. Methylation was assessed using the chip analysis methylation pipeline and using the Limma and Kate packages in RStudio. Our team consists of our principal investigators, colleagues who did the lab work of this project, and our statistician as well. Overall, we obtained 2 significant CPG sites that were associated with cognitive impairment, one in Mexican Americans and one in non-Hispanic whites. Our most significant hit was at an FDRP value of 0.029, and this was within a CPG site within the CREB binding protein gene. And this gene has been associated with memory formation, and the specific site has been associated with pineal development affected by fetal malnutrition in a Chinese cohort. This gene specifically is a histone acetyltransferase and is therefore an epigenetic regulator, which is indirectly involved in regulating methylation as well. So this correlates with our hypothesis that environmental factors might play a role in influencing risk for cognitive impairment. Our second hit was within the non-Hispanic white group, and this was within a non-coding RNA that is involved in synapse assembly and also nerve development. The specific CPG site has been reported before, to be associated with the Chinese cohort that I mentioned before with pineal development, and the CREB protein binding gene hit was associated with post-traumatic stress disorder, just to correct that. These CPG sites of our suggestive hits, the EPHA4 gene has been associated with, this gene is associated with, is expressed in the hippocampus and is also established in Alzheimer's literature to be associated with Alzheimer's disease. Overall, all these hits might be used in the future to develop cognitive impairment risk assessment that might be used to aid therapeutics in the future that might delay or prevent cognitive impairment. And these CPG sites, this study is the first to report these CPG sites to be associated with cognitive impairment among Mexican Americans and non-Hispanic whites in this group. And the next slide should show our funding sources as well. Here's a list of that, and thank you for your attention.
The title of the next presentation is Neuropsychological Profile of Aging in Mild Intellectual Disability, a case report by Dr. Lubna Abdullah at UT Health Rio Grande Valley.
Thank you. Good morning, everybody. Last but not least, maybe the shortest. There's one more, I'm sorry. Okay, so my name is Dr. Lubna Abdullah. I'm a neuropsychologist and assistant professor of psychiatry coming from the University of Texas in the Rio Grande Valley. I'm super excited to talk to you all about a case I received that was for the differential diagnoses of Alzheimer's, but what I ended up finding is mild intellectual disability. So my slides aren't automated. Do I just? Perfect. So a little bit of background on the topic. We know that within the intellectual disability with Down syndrome population, there is an increased risk for the development of Alzheimer's. This is primarily driven by trisomy 21, which drives the production of beta amyloid. However, when you look at the literature, there's not much with regard to the intellectual disability without Down syndrome population. And as this population is aging longer into their lifespan, with age being the biggest risk for Alzheimer's, it becomes exceedingly more important to figure out what is abnormal and normal aging in this population, what are sensitive batteries to detect, nuanced change in a population that already has pre-existing deficits. I am just a peon in a larger project we have in the University of Texas in the Rio Grande Valley to really connect the community to access early intervention and detection, right? And so here, as we talk, as Anne talked about, with an increased risk of development of Alzheimer's in the Latinx population, we are one of the leading areas for health disparity. And this is also seen with regard to Down syndrome. When looking at the Texas Registry of Birth Defects from 1998 to 2018, while there's a national prevalence of about 1% of Down syndrome, here in the valley from Laredo to Corpus Christi is about 16%, right? So has that same, theme. And many of my colleagues are trying to investigate what is it? What is the multifactorial etiology of these phenomenon? And with the Institute of Neuroscience and my colleagues in neurology and psychiatry, we all work together to sort of bridge this access and care. And I'm very proud to say I am the pioneering professional to bring neuropsychological assessment to our School of Medicine in 2020. The main purpose of discussing this case with you all is to get more specific with regard to our definitions of aging use in this population, identify what sensitive batteries you can use to detect change, increase awareness of maltreatment and their unique experience of individuals in this special population, as well as provide some guidelines for intervention. So this is a 67-year-old Caucasian male who reports to the clinic after a psychiatrist reports to Adult Protective Services as 2 homeless individuals have bartered with him to live in the home in exchange for home health care, which of course they didn't provide. He also attempts to boil a glass bowl on a stove and it explodes. Thankfully, he doesn't get injured, and this is the context of the referral. Much of his developmental history is unknown, but he does report a severe beating that happened as a child, and then he was reared in an orphanage, which he called, I was institutionalized. And upon, after leaving the NICU and upon being at the orphanage, he does not know how to kick a ball, write, read, all those developmental milestones, and he reports a 15-year-old at the orphanage, which he regards as his mother, taught him most of those things. Educationally, he sort of drops off after 8th grade, but does report he got C's and D's and F's and really was just kind of pushed along. His adoptive sister is there for collateral. His adoptive parents are deceased. He's adopted at age 15. And again, he has a prior diagnosis of PTSD, depression, 2 previous suicide attempts, but no history of mild intellectual disability, no intellectual components. With regard to his background, there is a longstanding history of problems with independent living, and his adoptive sister does report, for example, while in Vegas, his car breaks down, and instead of fixing whatever the issue was, he buys an entire new car. So all of this predates, the reason for referral. I please urge you to come visit my poster, number 40, because it's a very dense battery, and I can only talk about just a little bit of it. But since I didn't know there was going to be intellectual disability, I gave him the Wechsler Adult Intelligence, and he eventually was not able to complete it. His emotional tolerance, distress tolerance was not really able to manage, the difficulty. And so I then went to the RIAS-2, which involves a little bit more of deductive versus inductive intelligence. And you'll see that he does meet criteria right there at the cutoff with the IQ of 64. But interestingly, you see the verbal component of the RIAS is almost reaching normal threshold. So I think that because of the deductive nature of the RIAS and the deductive nature of conversation, I think that's why most of his life his intellectual disability went undetected. Now you may be wondering, how do we then ascertain if someone who already has memory and executive deficits, how do we know that this isn't actually Alzheimer's, right? So we compare their intellectual functioning to their actual scores in their profile, and all of this was consistent with his intellectual functioning. Moreover, we would expect that abnormal aging in any population still follows an amnestic profile, and his memory profile was not really fitting that. And he actually had pretty improbable memory presentation. He would mull over things that he thought he got wrong the day before, and then obviously consolidating that new memory. Interestingly, with the neuropsychological assessment battery, when corrected for an 8th grade education, he was able to meet normal threshold and otherwise moderately impaired scores. And so I think there is some promising utility of the NAB in this population. And he does present with intractable anxiety and depression, lots of factors with regard to dynamic trauma, which do come out during his assessment. And all of these all of the problems with adaptive functioning predate, like I said earlier, any of the new referral symptoms. And so the big conclusion here is that getting better definitions to use in this population, finding out which sensitive batteries can detect the nuanced amount of change that's required to even ascertain abnormal aging is certainly needed. Also, I want to shed a little bit of light on the psychosocial and ecological factors that impact this population with regard to maltreatment. And it's unclear whether the mode of contraction of ID, congenital or acquired later in life, changes this direction or moderates this direction. And so I hope that this jogs your interest in this special population that oftentimes doesn't really make its way to these types of conversations. Thank you.
Now we have the last presenter of the session, it's Dr. Juan Pablo Pallavicini from UT Health San Antonio.
Hi there. Thank you. So I'm here on behalf of Juliet Garcia Rogers, who unfortunately couldn't make it. She turned positive yesterday for COVID. I'm excited to tell you about this new project we have on this PLCG2 new risk variant. And Juliet is co-mentored by Sarah Hobb from the Biggs Institute, who is here in the audience, and myself from the Barshop Institute at UT Health. So, excuse me. PLCG2 stands for phospholipase C gamma 2. And what it does is it cleaves a lipid. And by doing so, it basically generates important signaling messengers in the brain. And so there are two rare variants of PLCG2 that have been associated with Alzheimer's. So one that decreases or is a protective, the P522R, color-coded in yellow, and one that is confers risk for the disease, the M28L. And this is for late onset Alzheimer's, which of course is the majority of the cases. Now, we still don't know much other than the fact that these variants are associated, so we are trying to understand the molecular mechanisms, taking advantage of new model Alzheimer's, new models of late onset Alzheimer's that have been recently generated by Model AD. All right, and it should advance soon. All right, here we go. So we have color coding PLCG2 wild type in green, and then the protective variant is in yellow, and the risk variant is in red. So we went through a number of assessments, and this is the initial characterization we've done so far, including behavioral and phenotypic studies. So by doing the Barnes-Maze first, we assessed learning and memory, and so there was mild but significant effect on memory in the risk variant that was both in training and also on the memory itself on the probe trial below. Then subsequently, we also did this frailty index scoring, where we basically is a proxy for health span and to get an idea of how they are aging. And so we also found significant effects on the risk variant, which had higher scores, suggestive that they are aging faster. And then we also look at other measures. In fact, we're currently running fear conditioning, and we're getting very similar results. We also run novel object recognition, and there we didn't see any differences. We also look at their weights. The females had a little bit lower weights of both variants, and then glucose homeostasis was not impaired. We also are starting to sacrifice this cohort of mice. We saw thymic shrinkage or involution in the risk variant, again, consistent with the notion that they seem to be aging faster. All right, and so in conclusion, basically we saw good evidence of the risk variant, as we would have expected, has a negative effect on memory and learning, and seems to accelerate aging. Surprisingly, I guess, contrary to our hypothesis, the protective variant didn't seem to have much of a positive effect. We think this may be due to the fact that these animals are homozygous, and in humans, of course, it would be only one copy, so which has been previously shown in vitro to be a hypermorph, meaning slightly more active, and maybe just having too much of it, we thinking is impairing its positive effects. So we're looking forward to continuing characterizing these animals. We're planning on doing multi-omics studies, which we actually have recently performed on the full knockout, the full PLCG2 knockout. And I invite you to hear more about this story on poster number 6, and also we have another poster on the effects of lipid metabolism after depleting microglia, poster number 29. Thank you.
Well, this concludes the session, so thank you very much for attending.
We will now take a short break and meet back for the keynote address in Zlotnik at noon.